Hello once again, everybody. Mr. G here with all the stuff you need to know concerning chapter number 4 from this month's course for exercise programming in special populations. This one, we are going to talk about metabolic conditions and disorders. Keep in mind here, we will go over what it is, what you can do to treat it from a treatment standpoint and medication specifically. And remember, we need to know medications because those also might present some boundaries and some roadblocks for us to work around when coming up with our exercise programs. And then we will also talk about the benefits and effects of exercise on each of these metabolic conditions and disorders. So let's get right down to it. All right, so we've talked a lot about what causes these, and we're talking now again about metabolic diseases, and a lot of it has to do with our lifestyle choices and the increased risk that those put us at. Things in this category that we're talking about here: type 2 diabetes, dyslipidemia, and obesity. These are strongly linked to lifestyle choices. Yes, there are exceptions to that, but mostly the reason why we have these issues is because of our poor lifestyle choices. Very few people in the United States follow a low-risk lifestyle. According to the stats we've got here, 3 to 8%, which is pretty darn small. You might ask yourself, so what is a low-risk lifestyle versus a high-risk lifestyle? And there's a little table on page 110, table 4.1, that kind of breaks it down. They look at 5 different categories, 5 different components of lifestyle. They look at exercise habits, diet quality, smoking, BMI, and alcohol intake. So on the low risk side of things, in the exercise habits, that's all your ACSM recommendations for exercise. 30 minutes or more 5 days a week of aerobic exercise, 2 to 3 hours per week of resistance training, or that's 2 to 3 times per week, all your major muscle groups, regular flexibility exercise. So those are your low-risk lifestyle habits for exercise. Diet, they recommend low-fat, high-fiber, higher fish intake, low meat, moderate nut intake, high intake of fruits and veggies, low glycemic whole grains and legumes, and low-fat dairy. Those are the things there. Smoking, don't smoke. BMI, be in that healthy range. That's that 8, well, according to them, 18.9 to 24.9. And when it comes to alcohol intake, that moderate intake of alcohol, which again is 1 drink per day for women, 2 drinks at most per day for men. High risk on the other end. So remember, only about 3 to 8% fit all of that criteria. Smoking is they smoke. Greater than 30 is BMI, so that's a high-risk lifestyle. 3 or more drinks per day. If your diet consists of high fat, low fiber, high cholesterol, meat, lots of high fat dairy, low fish, low intake of fruits and vegetables, and those high glycemic grains. And then, of course, sedentary behavior. And those are sadly the normal behavioral patterns for most Americans. And that's why that low risk lifestyle, 3 to 8% is all we're seeing. And that'll lead us to a number of different types of metabolic disorders. So the first one we will look at is one that we have discussed over and over, and you'll discuss it until the end of time if you're going to be in this field, whether you're studying or not, because it really is tied and linked to everything, and that's what we're going to kind of go over here. Obesity, or as it should better be known as excess body fat, that's a result of chronic imbalance of how much you take in versus how much you put out. So your energy in is how much food you eat, and your energy out is how many calories you burn. That whole just nutrition balance is what we're looking at. And sadly, we are out of balance on the energy intake side, on that side's favor. That's not to say that there are not any genetic contributors. You'll hear that from people, that maybe their genetics predispose them to being obese. Now, that may be the case. We have seen that in terms of studies on genes and your genetic makeup. However, that's a convenient excuse more often than not. These are rarely the sole cause of obesity. We've seen a tremendous increase over the last 30 years in obesity, and now approximately 30% of the population is obese when you look at BMI. And that should tell you something. That should tell you that this is not just a matter of, oh, I have, my genetics predispose me to being obese. If we've seen such a dramatic increase and about 1/3 of our entire population is considered obese, it tells you that something might be amiss, that we're probably talking about lifestyle habits here. Excuse me. The CDC, in 2015, some stats here, 36.5% of adults and 17% of youth rated as obese, which is pretty wild, especially 17% of kids. Kids are not supposed to be obese. Kids are active, their metabolism is fast, they like to run around and move, and we're seeing high numbers. Obesity does get classified, broken down into further stages. We already know that a BMI of 30 or greater is considered obese, but if you want to break it down even further to higher stages, you got stage 1, stage 2, and stage 3 obesity, and that's when that BMI is at 30 up to 34.9. That's stage 1. Stage 2, when you get over 35 till right before 40, and then stage 3, or morbid obesity, is greater than or equal to a 40 on your BMI. Now, about 1/3 of the population is obese, but more than half the population is considered overweight, which is that 25 to 29.9. So needless to say, this is an issue that is probably going to set us up for a lot of the other issues we're going to talk about in this chapter here today. More about our lifestyle here, the diet that we consume here, the Western diet of the United States and other developed countries. High fat, lots of simple sugars. What those do is they will actually promote weight gain. It can result in symptoms related to other chronic diseases like inflammation and even some vascular dysfunction. There's some debate on the Western animal-based diet versus a plant-based diet, and we can look at a table on page 111 there. Really what that table does is it breaks down the advantages of being more vegetarian-based or having more of an emphasis on plant-based sources of food versus animal-based sources. We've got lower fat intake overall, both saturated and trans fat. A little bit lower protein intake. The carbohydrate intake is a little bit higher on the plant-based side, but when it comes to the types of carbohydrates, simple versus complex, we want more of that complex carbohydrate, those high fiber and that sort of food choice versus the simple. And the animal-based diet, Western animal-based, you're getting the opposite. You're getting those simple sugars, which are processed and not quite as good for you. Low fruit and vegetable intake versus high, low grains, all that. What it really breaks down to is that whatever you've thought about it before, there are some pretty significant advantages of having a plant-based diet versus our normal Western animal-based diet. Now, this is also compounded. This is just the dietary side of it and the choices that we make and why they're poor for us. But when you combine that with the fact that we're not as physically active, and even if we are active, we have longer bouts of inactivity in general, those increase our risk for a lot of these negative metabolic disorders. Obesity itself also interferes with your normal appetite control, and that is caused by a lack of response to the hormone leptin. Leptin is a hormone that promotes you being satisfied. So that word right there, a satiety hormone, that's about being satisfied. So when you eat food and you feel like you've had enough, and that's produced by adipose cells. So we might have that altered as a result of being obese, so you never quite feel satisfied. So that urge to continuously eat more food is there, and that contributes further to this obesity problem. However, it has been found that exercise might be a good way to help reverse this issue. So, obesity, how do we treat it? Are there medications? Well, the answer is that there's no medication produced that can address everything. There are some medications out there, but they're on page 140, table 4.1. If you look at that list, though, it's kind of scary. You know, people are trying to take some magic weight loss pill or ways to kind of help block absorption and digestion of fat. But some of the side effects, the common side effects of a few of these medications are really, really wild. I'm looking just at the last one on here. It's an extended release form of naltrexone and bupropion. It's called Contrave. But it says right here, most common side effects of this drug that's trying to help alleviate issues associated with obesity: suicidal thoughts, seizure risks. I mean, is it worth really taking these kinds of medications? I know people want an easy answer, and there are medications out there to treat it, but that's really not the best way. However, when it comes to people that are obese, remember, obesity is usually a precursor and is associated with a lot of other disorders. So they might be taking other types of medication to treat those other obesity-related diseases. The reason we talk about medications, and we'll continue to talk about medications in this class and in this PowerPoint when it comes to these metabolic disorders, is because they have an effect on the body that you, as an exercise professional, are going to need to know about, because that might impact the kinds of exercises and the types of programming that you choose for these people. Energy balance, that's what we were talking about before. Effects of exercise. Let's just kind of break down the energy balance equation here. It is a combination, the net sum of your RMR, TEF, and the EEPA. That's a lot of letters there, but what they mean is your resting metabolic rate, so how many calories that you burn while you're at rest. The thermic effect of digestion, or for TEF, it's thermic effect of food, is how you've probably heard it before. And that's the amount of energy that's burned by just kind of breaking down food. There is an energy demand there. And then the thermic effect of physical activity. So when you exercise, you're going to burn some calories or burn some energy. If you want to reduce your body weight, if your obesity is the issue and you're looking at reduction of body weight, the best way to do it, put that stuff aside, what we were talking about when it comes to medications. It's optimally achieved by putting together a decrease in your calories, so eating less, and a comprehensive exercise program that has both aerobic and resistance training. So more activity, less calories. What you'd be looking to do for what's considered healthy weight loss, it's only 1 to 2 pounds a week, and hopefully it's coming primarily from fat loss as opposed to coming from your lean mass. Now, you can do this by one or the other. You can lose weight by diet. You can lose weight by exercise. However, they are not as effective alone as they are together. They don't necessarily help with maintaining healthy fat loss over the long term. So the best thing to do is to change those eating habits and increase those exercise habits together. They work best when they're used in connection with each other. And of course, last thing here before we move on, energy balance is best maintained when there is a lot of exercise. So yes, diet is a crucial, integral component, because you can't outwork a bad diet, right? You've probably heard that before if you're someone that's into the gym. But at the same time, even having a pretty decent diet, it's not going to be as beneficial, and it might not help you maintain good energy balance and good weight loss unless you are also very physically active. So, exercise here. Again, this concept of isolating diet versus exercise. So if you just diet, let's say you go through some fad diet or some calorie restriction and you go into that, without exercise, weight loss can come from both fat, so you will burn fat, but you will also lose some of your lean tissue, and that is something we don't want to happen. It's more difficult when you lose more lean tissue because it negatively affects your resting metabolic rate. Remember, if you remember from some of our old classes, if you have more muscle mass, more lean mass, there's a higher metabolic demand to upkeep that type of mass. So what that means for you in simple terms is that if you've got more lean mass, your body actually burns more calories just because it's leaner and it's trying to maintain that. If you burn off lean tissue, then you're not helping to increase that resting metabolic rate. In fact, you're slowing it down, so it takes longer and it's harder to burn calories. Now, losing weight is difficult. Preventing weight gain is actually a lot easier to do than losing the weight altogether. As fitness professionals, if we've got people that are looking, that are obese or they're looking to lose weight, what we should do is we should strive to encourage them to maintain a healthy lifestyle with a reasonable diet. Remember, we are not dietitians, but we can give some good information and some good suggestions of what people can do to maintain that reasonable diet. And we should encourage them to sustain enjoyable physical activity that is integrated into their lifestyles. Remember, that's one of the biggest things about exercise choices. People have to like it. If they like it, they'll keep doing it. If they don't like it, they won't. And we do want to promote adherence to these new, better, active lifestyles. When it comes to diets, we've got 4 types that you typically hear about. You've got a low-calorie balanced diet, low-fat, high-carb diet, low-carb with high-fat, high-protein or both, and low-carb, low-fat with high protein. Now, what I'm going to have you do here as your little Easter egg assignment that shows me that you were paying attention to this particular chapter is I want you to go over to page 113, and what I would like for you to do is write me an email that says, I want you to title it Obesity. And in that email, I would like for you to give me the description of what each of these types of diets are. So rather than me just read them to you here, I want you to go to page 113 in your book. You'll see there's a little bullet point for each of these 4 types of diets and a pretty full description of each of them. I want you to give me the description of each of these diets, and that will let me know that you guys are doing what you're supposed to be doing in the time that we're not in class. Because again, this is hybrid. That doesn't mean it's just 2 days a week. It means that we meet 2 days a week. You're still working the full amount. So please make sure you go to page 113 and give me the description of these 4 types of diets. That's your assignment. Don't share it with others, because then they'll know to just come to the 16 or 17-minute mark of this lecture. I want you to make sure that you're listening, that you're picking some things up that will help you as you learn more about special populations. A 5th one there, which I'm not looking for you to give me anything on, are very low-calorie diets with just lots of restrictions. So that's an added one there. Now, when it comes to any diet, can they be effective? Well, the answer is yes. Any one of these diets, any one of those fad diets you've heard of, the question here is, can they be effective? Of course they can be effective. They will result in some kind of weight loss. However, a good diet should be evaluated for adherence to the concepts of energy balance, and these need to be sustainable to be effective. You can crash diet all you want. You'll lose a bunch of weight. Maybe you'll lose it fast. Maybe you'll get down really quick. But if you don't hold up the good concepts of energy balance and getting the right amount of macro and micronutrients, and if you do stuff that's too much too soon and that is not sustainable for your entire life, then you're not doing this correctly. Think about a show like The Biggest Loser. The last season that they did of it, I think, was like season 8, and it was a while back. But what they found was that after they could put those contestants on that show and they were working with these trainers and they're just training all day, every day, just burning tons of calories, tons of weight, and whatever the length of time it was, and some of them lost hundreds of pounds. When they followed up with them several years later, every single person on that show, with the exception of one, actually rebounded back to what their weight was when the show started. Some of them were even worse off, and then because they went on such a crazy crash diet and they were exercising so much and they were not working their jobs, they were under direct supervision, it was just not realistic. It wasn't sustainable. they've actually damaged their metabolism to the point where now when they've done tests on their resting metabolic rate, they have found that even for someone their size with a slow metabolism, they are significantly behind other people that are in that category because of the crazy yo-yo effect of what they did to lose the weight in the first place. So yes, these kinds of fad and crash diets, they can work, but in the long term, they are not going to give you the results that you want. Other things to keep in mind here with obesity, their environment, what they're surrounded by, who's around them, and some other factors pertaining to their lifestyle should be taken into consideration because those can have an effect on the success of the program. If they don't have good people around them, they're going to build them up. If they're in an environment where they're not really allowed to be active and they can't really do the steps necessary, those are all going to impede the progress of any program you design. So helping to optimize their entire life and their lifestyle is going to help with the most success for this. So what do we do? If you have an obese client, there are some exercise recommendations. You can find them in table 4.3. We'll go over a couple here. Keep in mind a couple things about obesity. If you're working with an obese client, typically they are not as tolerant to exercise and they are more injury prone when it comes to weight-bearing exercise. So they can't do as much and they're more likely to get hurt than the average person. So you got to keep that stuff in mind. If you're going to do some weight-bearing exercise, just do it less than you would with an able-bodied individual. So lower duration, less often, less intense. You might want to start with those short bouts, 5 to 15 minutes, several times a day are more optimal to start. So you don't have to do a 60-minute session. You could do 4 15-minute sessions. You could do 10 5-minute sessions to get up to 50 minutes or so, or 12 if you want to get to 60. Whatever it takes. That might be better tolerated by someone just starting out. If someone is really looking, though, to lose weight, they're going to need to go over what the general recommendation is from ACSM. I know we usually talk about 150 minutes per week. With an obese individual, we're going to really be focusing on that cardiorespiratory exercise, moderate intensity activity. Instead of 150 minutes, you're going to look at about doubling that. So about 300 minutes a week or more in order to supplement weight loss from caloric restriction. Again, you want to make sure that you're preventing lean mass loss as well, because again, stripping the calories down, sure, you'll lose lots of weight, but it's going to come from wherever it wants to go. If you're still working, if you're still active, then you will promote the development of that lean mass and you'll hang on to it, which is again better because it will increase the metabolic demand of the body and that'll help to burn more. So good combination is what you want to seek to achieve when working with the obese client. Same thing with resistance training here. It might not result in significant weight loss, but it is helping with that lean mass. So it might prevent significant loss of that fat-free mass. We want to hang on to our fat-free mass. Some other modifications, precautions, and contraindications for obesity. They are more prone to musculoskeletal injuries and diseases, so things like osteoarthritis and hip, low back, neck, and knee pain. A carefully graded progression, so you don't want to progress too much too fast. Aerobic and resistance training need to be initially performed intermittently in short bouts, and then you can eventually work your way up. You'll focus on increasing that duration and that frequency before you increase intensity. So if you're looking at that, don't just add more weight or don't make them go faster. Focus on making them do this longer. And then once you've achieved some of your goals there, then you can start messing with the intensity. Some machines, depending on how obese your client is, either need to be adapted to their body and in order to be used safely and effectively, or some of them might not even be able to be used at all. As a professional, you're not going to be like this person, but you do need to be sensitive to both their physical and emotional difficulties. If they're in there and they're trying to make a lifestyle change, then that should more power to them. That we should see that more. I wish that we did. But at the same time, they are going to be embarrassed. They're going to be insecure. It's not going to be the most easy thing for them to do. And therefore, it's recommended that it might be better to work with someone individually. So working with a trainer is oftentimes advised over going to a group class or working in a facility in front of everyone, because then you eliminate some of those pressures and that lack of confidence and that lack of competence in what to do, because those can affect whether or not they're going to stick with it or not. A lot of physical and emotional difficulties that go along with obesity. Once again, obesity is oftentimes very related to other metabolic disorders. So as a result, if you have an obese client and due to that high risk for metabolic disorders, you want to make sure you keep an eye on the following areas when it comes to assessment. Looking at body fat percentage, their weight, their blood pressure, their fasting blood glucose and lipids. Now, some of that stuff might be done in the doctor's office, but it should be assessed every 3 to 6 months, really to look and see what kind of progress is being made and whether or not that profile is improving for the better, which is why they're there in the first place. Blood pressure should be regularly monitored before, during, and after exercise. That is a common practice. Make sure that you encourage them to take in lots of fluid. You want to make sure that they stay nice and hydrated, and be attentive to keeping a good temperature in the facility. They recommend between 66 and 72 degrees Fahrenheit because people who are obese are prone to overheating, or otherwise known as hyperthermia. Moving on now, the next metabolic disorder, type 2 diabetes. This one comes up quite a bit. It's characterized by a resistance to insulin or an underproduction of insulin. It prevents an adequate control of a person's blood glucose levels, or BG. So whenever you see BG, that means blood glucose levels, so blood sugar. And type 2 diabetes can also lead to some other issues like dyslipidemia and some other side effects as well. Classification criteria are listed on page 118 of your textbook. You'll see the fasting blood glucose levels. But the big thing here, type 2 diabetes is 30 times more likely in people that have a BMI over 35 compared to normal. So if someone is in the normal category, they are 30 times less likely than someone who has a BMI over 35 to develop type 2 diabetes. So this is why obesity matters and why obesity will continue to come up as we go into these metabolic disorders. The more obese you are, the more risk you stand to develop and contract some of these other issues that are pretty significant. And of all the different types of diabetes that we have, type 2, which is what we're talking about right now, that's the most common. That accounts for between 90 and 95% of all diabetes cases in the United States. So we'll talk about type 1 and how that's not lifestyle related, but that's also a very, very small portion of this discussion. Type 2 diabetes, which is usually lifestyle related, is number one by leaps and bounds. There's the table we're talking about with the numbers there. These are numbers that you might get asked about from time to time. So know them, be able to recognize them, have an idea what they are, that fasting blood glucose, and then what the blood sugar looks like 2 hours after taking in some glucose, and 75 grams is the dose that they've measured it. So those are some of the classification criteria. Depending on what numbers you get, will tell you what the person is. Are they normal? Are they considered pre-diabetic? Or do they have diabetes? So about that high blood glucose level, that high blood sugar, it is associated with other related conditions such as coronary artery disease, which can lead to heart attacks, congestive heart failure, cerebral vascular accident, or otherwise known as stroke. So high blood sugar can lead to more likelihood of a stroke, high blood pressure, kidney disease, bad cholesterol. You'll have low HDLs and high triglycerides, eye disease. So this can actually affect your vision. It can affect your peripheral limbs, your arms, your legs, your hands, your feet, heart rate, blood pressure, body temperature. And if you've ever seen someone that has some peripheral artery disease where the arteries that are carrying blood away out into your more distal limbs, so down into the feet and the arms, the lower, in your hands and feet, your lower arms and your lower legs, that's all going to be impacted potentially by having this high blood sugar. So type 2 diabetes is pretty serious. It's not just something that is a number that we talk about. It has some pretty profound physical effects. There's a lot of medication out there. You need to know some things about it just so if someone is taking it, you know what it does and how it's going to affect exercise. It's usually used to decrease that resistance to insulin in the first place. It might reduce glucose secretion by the liver, so the liver does not put out quite so much glucose. Or it might stimulate more insulin production from your pancreas, the beta cells. So there's a little list on there with medications designed to talk more about this topic. We don't have to get too much further into it for our purposes. They might also use fake insulin, artificial or synthetic insulin. Medications for related conditions are also common and must be accounted for. Remember, a lot of these disorders that we're talking about, oftentimes they don't stand alone. So you don't just have type 2 diabetes. You're not just obese. You're also, and name whatever disease you want to name. And if someone's taking those medications, they all kind of stack on top of each other and they make your job a little bit harder when it comes to picking the right types of exercises. Now, the meat. Why should people do it? What's the benefit for them if they exercise, if they have type 2 diabetes? Well, exercise can actually help to control that blood glucose level. When muscles are active, they can actually stimulate glucose uptake by the muscle cells. So they can actually pull in the floating glucose out there in the blood, use it for something, and that's independent of even insulin that's out there. So that muscle activity is going to be beneficial. If you have an improved diet in a comprehensive lifestyle modification program, which again, you're looking to modify things, it should be your entire lifestyle that's looking to be improved. We've seen in studies that exercise actually significantly reduces the risk of the development of type 2 diabetes in people over 55. And remember, we've talked about the natural degenerative processes when you get older and how people become more inactive. So the fact that this can actually, exercise can help to alleviate some of the issues and the likelihood of developing type 2 diabetes in older adults, that's a great thing. Resistance training also has a couple of positive effects. It, again, stimulates that glucose uptake by the muscles. The effects of exercise seem to have actually better outcomes than the medicines that people take. Now, yes, it requires more work, which is why I suppose medication is more popular, but the effects do generally seem to be better when someone exercises versus when they take some kind of drug to help manipulate their biochemistry. Similar to some other things we've seen with type 2 diabetes, start with short bouts, again, 5 to 7 days per week, getting up to that 150 minutes or more. You're looking at an intensity between 50 and 85% heart rate reserve. A couple of modalities there, walking, biking, swimming, anything that's large muscle, rhythmic, continuous exercises. If you're looking to lose weight along with this, and again, these two things go hand in hand, don't just think about 150 minutes. You're going to want to double that. So looking at maybe 60 minutes a session is what you want to work your way up to, and do that 5 times a week, and that's going to give you about 300 minutes. So that was cardio resistance training, total body, every couple days, so 2 to 3 times per week. 2 or 3 sets, 8 to 12 reps using large muscle multi-joint exercises. This is very much like general population. Lower intensity will be necessary for beginners, but as exercise is tolerated, you can obviously then begin to progress. Flexibility training, which again, very neglected in all populations, that'll be important because range of motion is sometimes problematic in diabetics, especially if anything is wrong with their arteries from a peripheral standpoint, being able to move. A little bit of flexibility training, getting them used to continuing to move through a full range of motion in all their major joints. That's what we want to seek to promote. If you're going to do flexibility training, the recommendation here is 1 to 2 stretches for each muscle group. Hold them for 10 to 30 seconds, probably a little bit closer to that 30. Now, those are the recommendations. There are some precautions. Someone with type 2 diabetes, if they have other diseases, that word again, comorbidities, they're probably going to need a medical clearance. Also, they might want to get a medically supervised fitness test. So that's a little bit beyond our scope. We need a doctor to sign off and make sure they're ready for everything that we've got coming their way. They should monitor that blood glucose very regularly, both before exercise and afterwards. If it is above 200, if the blood sugar is above 200 milligrams per deciliter, we need to not exercise until blood glucose is reduced, because that's a bad risk factor. We don't want to cause any undue stress and issues. Now, if there are any, an exception can be made if urine ketone bodies are absent. So if they actually get a measurement or reading on their ketones, and these show up when fat or protein are being burned due to lack of insulin. Ketones are a byproduct of that process of burning fat. In that case, light to moderate exercise is possible. So if there's not a lot of ketones in their urine, they can still work at that 200 milligrams per deciliter level. But remember, folks, instead of memorizing this, chances are a doctor's note will tell you more about it, and they're going to need that clearance anyway. Now, if their blood sugar is a bit too low, if it's on the low end of things, you might want to give them, well, not you, they should take a 20 to 30 gram of carbohydrate, a little snack, and then check their glucose level so it gets into a reasonably normal, healthier range, and there's enough glucose in the blood to actually use for exercise. Be careful, though. Be careful because it could result in possible dehydration. Diabetics that are on some medications, they might have increased urine production to get rid of the excess blood glucose. Their body is going to sense that there's too much of it, so it's going to do whatever it needs to get rid of it. If that's the case, they could become dehydrated, and that can interfere with their workouts as well. If they suffer from diabetic retinopathy, retinopathy has to do with damage to the blood vessels of the light-sensitive tissue at the back of the eye. So that's why we see retinopathy, like the retina, a part of your eye. If they have issues with this, they should avoid large increases in blood pressure caused by vigorous exercise. So you're going to want to keep the intensity down. Absolutely no Valsalva maneuver. If they have autonomic neuropathy, that's nerves that control involuntary bodily functions, kidney disease, peripheral artery disease, or peripheral neuropathy, which all of these things do happen in connection with type 2 diabetes, they need to be going to a medically supervised program. That is beyond our scope. Again, we need doctor's clearance and recommendations if that's what they're going to be doing. Be aware of, again, any comorbidities, any other diseases that happen along with type 2 diabetes, like cardiovascular disease, obesity, dyslipidemia, which we're going to talk about in a little bit here, and plan your exercise based on those considerations as well. Type 1 diabetes. Now, it accounts for a much lesser portion of the pie here, but we'll talk about it anyway. It's an autoimmune disease in which those pancreatic beta cells that produce insulin, they get gradually destroyed. If they have type 1 diabetes, they might have to get an insulin shot, so they'll be taking it exogenously, so it's coming from outside the body in order to help control the glucose in their blood. People that have type 1 diabetes, it's typically diagnosed earlier in life. It can occur at any age, really, but most likely way before the age of 30. It's something that you will pick up on much sooner. However, again, it's only 5 to 10% of the population of diabetics that even fall into this category. This is not lifestyle related. This is something that typically people are born with, that they have. So there's not much you can do in terms of prevention of type 1, whereas with type 2, it's mostly lifestyle based. Ketoacidosis can occur if your blood glucose builds up, which is the use of protein and fat as energy sources. So it's going to break down those to use as energy sources as opposed to using carbohydrates, and that could actually cause some negative effects in the body. Things like dry mouth, nausea, abdominal pain, muscle weakness, shortness of breath, mental confusion. So this is a condition that if someone has, it does need to be carefully and closely monitored because they can have some pretty adverse reactions if their blood sugar levels are not being managed well. There are several medication types. Typically, it is going to be injected intramuscularly or in the lower abdomen, inhaled, or via an insulin pump that they have attached to them. It's not usually going to be in pill form, and there are different forms of it. Some are rapid-acting insulin. It gives you a quick little reduction within 15 minutes, but it doesn't last too long. You've got short-acting insulin. It'll reduce blood glucose in about 30 minutes, and it'll stay in the system for 3 to 6 hours doing its thing. Intermediate, it does not reduce it until a couple hours later, 2 to 4 hours, but it is effective for up to 18 hours, so that's got a little bit longer lasting effects. And then speaking of long lasting, you've got that long acting insulin, which takes a long time to kick in, but it keeps your your blood glucose levels pretty even for about a full day. Exercise. It does have some good effects for our friends that have type 1 diabetes. Reduce HbA1c levels. Say what? That's indicative of average blood glucose and hemoglobin levels. Now, if someone has a higher level of this, that means that there's worse blood sugar control, and then there's more risk for complications. So exercise can actually help to lower these levels and therefore reduce the risk of additional complications from diabetes. It can help to improve body composition, lower blood pressure, better blood lipid levels, decreased mortality, so less likelihood for untimely death, and can decrease blood glucose during or after exercise or during subsequent sleep, known as nocturnal hypoglycemia. Moderate intensity exercise seems to be the sweet spot. That is best for controlling your blood glucose levels. Table 4.6 will give you the exercise recommendations. They are largely the same as for the type 2 diabetics that we talked about, but considerations for controlling blood glucose are, again, that closer monitoring of it. For type 1, they definitely want to monitor it. Get that little snack, 15 to 30 grams of carbs for sessions that are going to last 30 minutes or longer if their starting blood glucose level is under 100. If it's between 90 and 150, carbs might be needed to be consumed at the beginning of exercise and throughout, depending on how long the bouts are going to be. For someone with a high blood glucose level, exercise should only be performed if those ketones that we talked about before, if they are low. That was the same as what we said earlier. And then if they do have it in their low, even still with that high blood glucose level, light to moderate intensity at most. If it's over 350, delay exercise, administer insulin, and then exercise at moderate intensity. So follow the chain of command here, the order of things based on what the reading is. Moving on now, out of diabetes to your lipid profile, your dyslipidemia. This is abnormal blood lipoprotein concentrations, which leads to higher risk for atherosclerosis, heart attacks, and stroke. Now, atherosclerosis is the buildup of fats, cholesterol, and other substances in and on the artery walls, which can lead you more likely to have more heart disease and heart attacks or strokes. So that's why we need to be concerned with your blood lipoprotein concentrations in the body. How do we know that it's a problem? We've got higher total cholesterol, higher LDLs, which are those low density or bad cholesterol, elevated triglycerides, and then low levels of that good cholesterol. And we'll talk more about that in a little bit. That TC, or total cholesterol, represents the sum of all forms of cholesterol in the body. It's carried in the bloodstream and stored in muscle tissue as energy. High levels do contribute to that atherosclerosis we just mentioned. LDLs with VLDLs are the major carriers of cholesterol in the blood, and they will deposit cholesterol in the lining of the blood vessels. So therefore, if we have more LDLs floating around out there and they're carrying more cholesterol, guess what? They're more likely to drop things off in the arteries and clog them up, and that's that atherosclerosis we're talking about. So we don't want high levels of LDLs or VLDLs. Chylomicrons are small fat and protein molecules in the blood and lymphatic fluid that transport fats from the intestine to the liver and to adipose tissue. And again, with this, higher levels of these will also contribute to atherosclerosis. So we want to keep our lipid profile positive. More HDL, that can remove cholesterol from the blood and transport it to the liver where it can be used properly. So we want higher HDLs, we want lower LDLs. Keep the high high, keep the low low, and exercise can actually help us do this. Here are some numbers. Yeah, I recommend pausing it here so you can take these in and look at them a little more closely. Lots of medications. We've got a whole table for it. Now, we're not so worried about the meds here. Yes, you need to know them, and yes, they'll impact exercise. But what exactly does exercise do and lifestyle management do? I'll tell you this. You have to adjust your nutrition in order to improve this profile in the first place. That means less fat intake, more fiber, and reduce your total calories. When you've done all that, if you combine that with aerobic exercise, that will help to decrease your triglycerides and increase your HDL. So we're going to decrease something that's going to possibly put more stuff down and clog up those arteries, and we're going to increase the HDL, which will pick it up and take it to the liver where it can be utilized properly. That's what we do want. So aerobic exercise plus dietary change is going to lead to an improved lipid profile. Resistance training has also been shown to be effective. Here we go. Just like with anything, and when it comes to exercise recommendations, aerobic training, rhythmic movements with large muscle groups, so running, swimming, biking, walking, jogging, stair stepping, all good choices. 4 to 7 days a week, smaller bouts or longer ones, up to 60 minutes a day. Again, you want to get them moving, doing a little bit more often. That resistance training, same as what it is for the normal population, 2 to 3 days per week. 50 to 85% 1 rep max load, so that's moderate intensity. Flexibility training, 3 to 7 days per week. Very much the same as the general pop. We want to definitely, when it comes to someone with dyslipidemia, we really want to make sure that we increase that cardiorespiratory exercise. Big rhythmic movements, large muscle groups. Now, we mentioned medications. A quick note on that, the types of medications. If they are on statins, which are lipid-lowering medications like Lipitor, they might experience, as a result of this medication, enhanced muscle damage or pain and blunted gains in strength or endurance. So you need to be sensitive to that. Maybe lower intensities, maybe less duration. They might have greater DOMS, that delayed onset muscle soreness, and myalgia, muscle pain. So there's going to be more pain and discomfort associated with exercise because of this medication. So again, start low intensity and then carefully monitor symptoms. Do not overdo it. If it continues to be bad or gets worse, refer them out to a doctor. Hypo and hyperthyroidism. Let's talk about hypothyroidism, or the underproduction of thyroxine, or aka T4, by the thyroid gland. It is a main hormone produced by the thyroid gland, and what it does is it helps to increase your metabolism and will then regulate growth and development. So if you don't have enough of it, and it's not producing anything to increase your metabolism, you could see how that might become a problem. If someone has hypothyroidism, some symptoms: fatigue, not being able to tolerate the cold, muscle aches, painful joints, loss of bone mineral, lower cardiac output, bradycardia. Now, even though these are symptoms and we can recognize them, a doctor has to diagnose this. This can lead to goiter, which is the abnormal enlargement of your thyroid gland, or maybe potentially fatal myxedema, which is a swelling of tissues and skin, commonly in the face and hands. And this, again, could be potentially fatal. So hypothyroidism, no joke, and not something good to be talking about, but important for us nonetheless to know what it is. This can be caused by an iodine deficiency, which is a trace mineral that's found in seafood. It's found in dairy, eggs, etc. Autoimmune diseases like rheumatoid arthritis, cystic fibrosis, lupus, or thyroid removal. All of these could be potential reasons why someone might develop hypothyroidism. On the other side of this, hyperthyroidism is the overproduction of T3 or T4. Now, T3 plays a vital role in the body's metabolic rate. It also plays a role in the heart and digestive functions of the body, your muscle control, your brain development, and maintaining good bone health. Most common cause is Graves' disease, which is an immune system disorder. Now, quite simply, Graves' disease is a disease that is specific to the thyroid and just causes excessive production of these hormones. So that's what Graves' disease is, and that's the most common cause. Again, thyroid hormones, they regulate your metabolic rate, and overproduction, why is that a problem? Because we just got done talking about not having enough. What'd be wrong with having too much? Well, it can cause nervousness, tachycardia, increased cardiac output, heat intolerance, muscle weakness, and none of those sound very good, so that's why it's problematic. We want to be in the normal range. Now, they do have different mechanisms, but they can both lead to a decreased tolerance of exercise, slow recovery from exercise, a lower anaerobic threshold. Don't worry, the length of this is getting to me too. And elevated respiratory stress, so increased respiratory rates, so having to take more inhalations and get more oxygen more quickly. It can also mess with your heart rate, either take it down or take it up. So these are problems for the body, and these are problems for you as an exercise professional to know about, because if they can't tolerate it, if they don't recover quite as fast, if they can't work anaerobically quite so hard, or as a regular person that doesn't have this, if they have to breathe more frequently, shallow breathing, heart rate gets messed with. These are all things for you to consider when you're developing a program for someone that has hypo or hyperthyroidism. Lots of meds. There might be some synthetic therapy, synthetic hormones put in where they are looking to replace what was going on for hypothyroidism, replace what was lost. Lots of side effects, though, that can mess with the function of the heart, nervous system, muscular system, and the metabolism of that person. So things to be aware of there. Can also increase blood pressure and heart rate as a result of that treatment. So medications, again, good and bad there. For hyperthyroidism, treatment is primarily to prevent excessive production of the thyroid hormone, or thyrotoxicosis, and associated heart rhythm disturbances that go along with it. Anti-thyroid drugs are then given, and dosages are adjusted until you get to those normal thyroid hormone levels, which is known as euthyroidism. They might take beta blockers. Now, this is a common prescription. Beta blockers might be prescribed to prevent the effects of thyrotoxicosis, but because beta blockers also really limit your heart rate from really altering, deviating at all, it keeps it very steady. Therefore, when you start putting someone through an exercise protocol, even as you start to increase the intensity of exercise, their heart rate does not change. That can be problematic because you can really hurt someone because their heart is not doing what it's supposed to be doing to kind of go along with the amount of oxygen it's getting. So if you're doing any kind of aerobic exercise, aerobic conditioning with someone that's on beta blockers, you're not going to want to use heart rate as a measure of intensity, because typically we'll prescribe someone you look at your let's say you want to work at 70% of your heart rate reserve. Well, you're not going to give that kind of recommendation to someone who's taking beta blockers. Instead, when it comes to monitoring exercise intensity, you probably would want to go with something like the RPE scale. So see ratings of perceived exertion. So how tired are you? How hard are you working on a scale of 6 to 20, or the modified scale on a scale of 1 to 10. So what does exercise do to make these two things better now that we're done talking about them? Well, for hypothyroidism, it helps to lower cholesterol, increase metabolism, improve their mood, and promote weight loss. All good things. And for hyperthyroidism, it can help to reduce joint and muscle stiffness that's associated with that, improve that bone health, and increase that muscle tissue. So how can we program for them? What are some choices here? Primary goal is to get them down to a normal thyroid hormone level state and then carefully monitor them for any adverse symptoms that are a result. Once they're at that normal thyroid level, guidelines for healthy individuals can be followed. So that same ACSM standards and guidelines, 150 minutes of moderate to 75 minutes of vigorous per week. When it comes to aerobic exercise, 2 to 3 days per week of all your major muscle groups for your strength training, almost every day when it comes to flexibility. Kidney disease, or classified for severity based on the glomerular filtration rate from stage 1 to stage 5. That estimates how much blood passes through the glomeruli filter waste from the blood each minute. Even for me, these are tough words. Stage 5, so the most severe form of this, or end-stage renal disease. You've probably heard that term before. That leads to people being on dialysis in order to filter the blood, and these people are going to need a kidney transplant to survive. So you might get someone walking through the doors that has some kind of chronic kidney disease. How does that happen? How do kidneys become damaged? Well, a couple reasons. Might be because of inflammation, high blood pressure, high blood glucose levels. And again, remember, high blood pressure, high blood glucose, those could all be resulting from obesity. Everything is connected. That's why it's so important to maintain a good, healthy weight, healthy lifestyle. What it does then, it limits their ability to remove waste from the blood, so now they can't get rid of it, which then results in damage to other organs. People that have this, the chronic kidney disease, they might have muscular fatigue because of vascular dysfunction and insulin resistance. The functional capacity with end-stage renal disease is only 60 to 70% of someone's normal. So if they need to have any kind of exercise test done to see how hard they can work, we can't do it. That's got to be done in a clinical setting. As it progresses, that end-stage renal disease, individuals are less likely to be physically active just because they're in a bad way, and their functional capacity will continue to decrease. Lots of medications will be administered to treat the other diseases that go with it. like heart disease, diabetes, hypertension, dyslipidemia. Most common medications, diuretics. These will prevent edema and fluid accumulation, but they can also promote dehydration. So that's something to be concerned with. Anti-hypertension, anti-hyperglycemic drugs. EPO, which is a stimulating agent to treat anemia. We need to know a little bit about all of these medications. And so that's why the tables in the back of this book, this chapter, you can go on the internet. If somebody comes in and they're taking meds, that's why we go through those pretty advanced screening tools and make sure we know as much as we can about our clients, because if they have any of this stuff going on, we need to do our homework on these medications and figure out what kinds of exercises are going to be acceptable for these folks. So what can exercise do to make things better for someone with chronic kidney disease? This is getting down to the very end of it now. Functional capacity increases in a similar manner to those without end-stage renal disease. So they can actually just get better at breathing and using oxygen and pumping it through the heart and getting it to the body. There's also an increased ability to carry out those activities of daily living. So this is not going to transfer just to exercise-related behaviors. This will help them with things that they need to do every single day. It'll lead to better muscle strength when you add more resistance training. So there's a lot of benefits here. Lower blood pressure, less inflammation, decreased cardiovascular risk factors. There's a lot to be said for the impact of exercise for people that are dealing with chronic kidney disease. And finally, to close this out, the exercise recommendations. So what can we do to give them to them? Well, go back and listen to what I said about diabetes and what we talked about with hypertension. Modified based on the functional capacity of each individual, but pretty much the same kinds of exercises, the same protocol. With most special populations, you're going to start with lower intensity and then work your way up. Most days of the week, moderate, 20 to 60 minutes. And then that resistance training, 2 to 3 days a week, one set of 10 to 15 reps at 70 to 75. Those are the recommendations. That's a little bit on the stuff we're talking about here with metabolic diseases. Thank you all so much. Hopefully you caught the Easter egg assignment earlier in this lecture. If you didn't, I recommend you go back and pay attention. There is a little assignment in there. Thanks so much, everybody. Enjoy listening to this. I hope that you do. And come back to me with any questions. Thanks, folks.